Good morning, everyone. I'm John Samet. I'm the Dean of the Colorado School of Public Health, and I'm delighted to be with you this morning or possibly this afternoon as we kick off this 2020 Population Mental Health State of Science Conference. Uh, I'm delighted to have the privilege of introducing this conference. I will say that over the 3 years that I've been here as Dean, this program, our Population Mental Health and Wellbeing program, has flourished in its research and training mission. And this conference represents part of its ongoing contributions to advancing the state of the science. Mental health and well-being will always be a critical topic, but at the moment, it is even more critical as we face the devastating consequences of the pandemic. Health, economics, and our well-being, our lives altered. Who doesn't have COVID fatigue at the moment? The topics laid out for today are timely and important, and I'm sure that there will be fruitful discussions. I congratulate the team for putting together this very timely conference at the right moment. I'm sorry that we're not able to be together, but in our new world redefined by this pandemic, we have learned how to function, and I'm sure that all will go well today. So again, welcome to the conference, and now I'm pleased to turn to my colleague, Dr. Frank Degree, Chair of the Department of Family Medicine, to continue on. Frank.
Thank you, John. It's my pleasure to participate in this conference and also to introduce our first speaker today. The plenary is actually a Leavitt Distinguished Lecturer. We have a tradition, a 40-year tradition of doing Leavitt lectureships here on this campus. And I'd like to introduce Dr. Lewis Leavitt to you prior to introducing our Leavitt speaker. Lewis Leavitt was born in 1896 in Denver. He was a vet and a physician. He went to medical school in Colorado and began practicing in Denver in 1927. Practiced for about 50 years until 1977, when he retired as a general practitioner in Denver. And upon his death, he had bequeathed to the Department of Family Medicine an endowment, which was to be used for bringing distinguished speakers to this campus to inspire us and edify us about topics relevant to the current health and healthcare situation in the world. We've had probably 80 Leavitt speakers by now. We've had some extremely distinguished Leavitt lecturers. And today, it's my pleasure to introduce you to one of those distinguished Leavitt speakers, which will be our kickoff lecture today. Dr. Ken Minkoff is a psychiatrist who is also boarded in addiction psychiatry. He does community psychiatry, and he has been making contributions to the healthcare field and to the literature in very important ways, having to do with patients who meet criteria for substance use disorder as well as a mental disorder, so-called dual diagnosed patients. These patients are extremely difficult, and managing them in an integrated fashion provides a way to think about their care that is much more effective and much more useful than keeping those two elements of their health siloed or partitioned. It is completely within the scope of this conference today to think about and talk about integration of those two elements of a person's health. We'll cover a range of other elements of health as we go along throughout the day. But let me introduce to you Ken Minkoff, who's going to talk about, listen to the title of this, Changing the World, Inspiring Hope, Health, and Recovery for people with behavioral health needs. And now, if that's not as inspiring as that first cup of coffee in the morning, nothing is. I want to join Ken, and I hope you'll join me in welcoming him to help us change the world. Ken, the floor is yours.
Thank you, Frank, and hopefully everybody can hear me. So listen, I'm honored to be a Levitt lecturer, and I'm honored to be participating in this conference on population mental health. And you know, as Frank said, I'm a community psychiatrist and an addiction psychiatrist, but what I do for a living is my wife and I have a small consulting company in Tucson called Zia Partners, which you see on the screen. And we've been working together for several decades doing what we modestly call changing the world, which means we work all over the United States and other countries, primarily with large systems like states and counties and different kinds of organizations, helping systems organize themselves at every level to be about the needs and hopes of people and families with all kinds of complex needs who are regularly showing up for help. And this kind of activity has a lot of fancy names like system transformation and system integration and trauma-informed systems and so on and so forth. But what it boils down to is, how do we organize our systems at every level to be about the needs and hopes of the people who are actually showing up? And, you know, as soon as I get done, Diane Primavera, who's the Lieutenant Governor of Colorado, will be sharing of particular interest to Coloradans a very inspiring and ambitious blueprint for health for Colorado, which puts this issue right front and center for what the state is going to be trying to do. And I'm hopeful that some of what I say can be informative to those of you in Colorado for thinking, how do we actually take this vision of how we want our system to be and how we want it to be different from what it is and make that a reality? And further, because this is a population health / public health conference, a lot of what I've chosen to talk about today is designed both for people who are running organizations and programs and systems, but also for people at the county and community level who are working from a public health or population health leadership framework and thinking, how do we bring people together in our community to figure out how to work collaboratively to improve the overall population health and mental health of our community, community altogether. So thinking about this, the biggest driver for recognizing that we need to redesign what we do in our system are the people themselves. And as all of you know, people show up at the door of the thing we call our delivery system, whether it's in the mental health side or the substance side or the health side or in human services. And they're presenting with all kinds of desperation and complexity. And they encounter systems and structures and rules and processes and bureaucracies that make it feel like the job of getting help when you're desperate and complicated is going to be really, really hard. Not only do the people we serve experience this, so do we. Most of us in this field went into this not because we thought this was a cool way to become a millionaire, but because we had the weird idea that we wanted to be about helping people. And we too go to work wherever we go to work inside the thing that we call our system. And we too find ourselves quickly immersed in the same structures that make it feel like our mission and values of helping the people in front of us is going to be really hard. And what we're starting to figure out, and what I want to put in front of you today to guide the conference and the things that are going to be talked about, is what we're starting to figure out is that we're never going to get where we need to go in systems with limited resources, simply by trying to fund special programs or special projects or hire special people to work around what often feels like a fundamentally dysfunctional system. What we need to be thinking about is how do we organize everything we do with every resource that we have. And by everything, I mean everything. Every process, every program, every policy, procedure, practice, piece of paperwork, every person providing help with every penny that we have to be about the needs and hopes of the people that we're serving and the values that brought us into this in the first place. Now, when we start these conversations, I'm organizing this in a particular way. So the first thing is I'm going to start the conversation based on the drivers, the values that we organize our system around, and how those values are connected to who the people are that we're trying to help. And then the next sections will have to do with how we organize ourselves into structures and partnerships and improving processes so that we can actually build entire systems around people with complex needs that are at the core of what we're trying to do from a value perspective. And I'm going to be referring to the overlap of mental health and substance, as Frank talked about, but because of the nature of this conference and the topics that are going to be covered, I'm going to be going further than that in how I talk about this today. So a value-based system of care means we design our system at every level to be about the needs and hopes of the people who come for help, as I said, and we are accountable for producing value in terms of how we serve people in accordance with our values. And where do we start? Well, one of the things that I like to do is to start by putting people in the middle of our conversation that we know the system has historically not been well designed to serve. And I call this the complexity challenge. And complexity means that there are people out there with overlapping issues of varying kinds being served in systems that primarily have been organized as if everybody had one problem only or only one problem at a time. So complexity can relate to people with both mental health and substance issues, to start within the domain of behavioral health. That is, any person of any age with any mental health issue, including trauma, combined with any substance issue or addictive issue, including gambling or even nicotine dependence, whether or not they've already been diagnosed. We can also talk about co-occurring or complex families, where one member might have one kind of problem, like a child with an emotional disturbance, and another member might have another kind of problem, like a family member or caregiver with a substance use issue, so that the family system needs an integrated approach. But we don't have to just look at mental health and substance. We can look at behavioral health, meaning mental health, substance combined, overlapping with intellectual developmental disability, acquired brain injury, or other cognitive impairments in all different combinations. Or we can look at any of those combined with any kind of a significant health condition, whether it's a physical disability, a chronic medical condition like diabetes, infectious disease. Individuals with multiple issues, as well as families with multiple issues. Now, why would we start with this particular group of people if we're thinking about system redesign? Well, first of all, wherever you look in the system, people with complexity are everywhere. And not only that, whatever complexity you start with, you immediately find that people are bringing other issues along with them. So not only do folks have mental health, substance health, and cognitive issues, they have medical issues, housing issues, legal issues, parenting issues, disability issues, financial issues, criminal justice involvement, racial barriers, cultural barriers, linguistic barriers to care. Not only that, what we know, rocket scientists that we all are in this field, is that the more complex you are, the worse you're likely to be doing. So these are the folks that are likely to be having the poorest outcomes and the highest cost in our scarce resource service system. And their poor outcomes are going to be in every conceivable domain. These are folks who are more likely to relapse and be rehospitalized. They're more likely to be labeled treatment resistant and non-compliant. They're more likely to engage in self-destructive or aggressive behavior. They're more likely to be victims of trauma, perpetrators of trauma, or both. They're more likely to be getting in trouble in some other system, costing us a lot of money. And most tragically, these are the folks who are most likely to die. And if our job collectively in this population health field is to design systems to be about the people who need us, then naturally we would be thinking that we already would have designed our systems at every level so that people and families with all kinds of complexities would be specifically, purposefully prioritized for care. But what we experience pretty quickly is just the opposite. These folks are mostly experienced as misfits at every level of the system. As I said earlier, these are folks who have dared to have more than one problem in systems and services that are designed as if everybody had one problem only or only one problem at a time. Programs are similarly designed, so those of you out there working with real people in real programs are constantly experiencing a need to contort your client to fit your program or your program to fit your client. In addition, these folks are misfits at the level of the skills of most people trying to provide help. Most of us are trained to think of ourselves as being a mental health person or a substance person or a health person or a criminal justice person or whatever. So when we encounter people with multiple needs, we immediately start experiencing a misfit between what they need and what we know. And they, of course, experience this as well, feeling, oh my God, here's another person acting like they don't know what to do with me. As a result of this, we're highly likely to experience the folks who need us the most negatively. They don't fit neatly into the box we've been given within which to do our job. And as a result, they stir up feelings in us, ranging from helplessness and despair to frustration and rage. So the folks who need us the most, rather than being welcomed and engaged as a priority for care, they're actually directly or indirectly held at arm's length. So one of the starting places for thinking about how to redesign our system is to think, how would we organize every aspect of our system so the people and families with the most complex needs are specifically, purposefully, and proactively welcomed for help, exactly as they are, wherever and whenever they show up. Now, what are we welcoming them into? Well, here's another aspect of this that's important. We want to welcome them into what I call the hope challenge. As most of you know, the driver for progress, particularly for people who have significant challenges, is the hope that by virtue of their effort and the challenge of engaging with us as the helpers, their lives will actually not only improve, but will come out okay. So in order for our system to inspire people who have complexity, we need to be in the hope business. Now, in framing it this way, one of the things that I'm putting in front of you is that talking about things like hope is not just like a nice idea. I'm constantly going to be coming back to the idea that the challenges of redesigning our system are organizational challenges, and we need to be mindful of the maxim that says every organization is perfectly designed to achieve the results that it gets. So one of the things we have to ask ourselves in a service delivery universe is, what business are we in? Are we in the business primarily of delivering billable units, or are we in the business of delivering welcoming and hope? Because how we organize ourselves to prioritize what our product is has tremendous impact on the lives of the people we encounter. So hope means that we are purposeful about inspiring people, especially those who are the most complex, who immediately we're not sure we know exactly how to fix, and we know we don't have the perfect resource for them, because those are the people who need our hopefulness the most. so that every person, every family, especially those with the greatest challenges, are inspired when they meet us with hope, purposefully for achieving a happy, hopeful, productive, and meaningful life. So the next question we ask is your system, organization, community, et cetera, designed so that everybody's on the same page about people with complex needs. The third thing is a challenge, and I add this in particular for those of you who are in the community population health business, is to indicate how do we identify who's responsible and accountable over time for people, particularly those who have the hardest time fitting neatly into the service box that makes them attractive for people to be connected to. And so, we've moved away, as many of you know, from a sense of population accountability to accountability for covered lives. If your insurance shifts, you no longer have anybody accountable for you. If your problem shifts, nobody's accountable for you. So one of the things to think about when you come together at the community level is that you're creating a shared accountability in that community for the folks who need us the most, okay? So when we're talking about principle-driven systems of care, which is part of what's in the Colorado Blueprint, the key, it's easy for folks to list all the principles, some of which I listed on this slide. But the key to doing this is thinking, how do we get to the point that all services are that? Not just that we have a few cool things that we point to that say those are special, but that everything that we do is in the business of delivering the product that's defined by the principles. And so one of the core values is to build things around the people that we're serving, our customers, the individuals with complexity, the families with complexity, as well as in whatever part of the system you're in, thinking about every single partner as a priority customer, so that everybody approaches you to say, my job is to help you be successful and to organize what we're doing inside my program and what I'm personally doing to be about your needs and hopes. Another core value is welcoming, as I said before, that we particularly want to welcome people who we know have experienced trauma and with every type of complexity that we can think of, because they're the folks that need us the most. And here are some typical examples of behavioral health overlaps where we need to be thinking about welcoming as a way of responding to diversity. And a way of helping to address health equity and overcoming trauma and all the other things that we're doing. But at the heart, it's making people feel like you're really happy to see them when they show up with every piece of complexity that they bring with them into your door. And we want to be hope inspiring, which is often called recovery oriented or resiliency oriented. But the core of what I want to talk about has to do with another reason for starting the discussion of transformation with complexity. Because not only are the folks with multiple conditions doing poorly, there are lots of them. And the prevalence of co-occurringness is so great that we say co-occurring or complexity is an expectation, not an exception, pretty much everywhere we look. It doesn't mean that everybody has multiple conditions. It just means that wherever you are in service delivery, the prevalence of overlap is so great that it makes little sense to have organized our delivery system on the assumption that it was rare. So there's plenty of epidemiologic data, but you can just look inside the service box that you're responsible for or the community that you try to serve. And you realize that these folks are in fact everywhere. And what we're learning is if our job is to design our system to be about the people that need us, we're never going to be successful welcoming the needs and inspiring the hopes of people with complexity simply by creating special programs, trying to find extra funding for special projects, hiring some extra people, or ensuring that everybody with multiple issues gets connected to multiple organizations, multiple funding streams, and multiple services, so that they can go get more confused and discombobulated, and we can go more, we can go broker than we already are. So we need to build the capacity inside our system so that all services are designed to welcome, engage, inspire, and provide integrated help to the people and families with multiple complex issues that are already there, not new people, the ones you're already serving. So this becomes a major framework for system redesign. So in the framework that I've been using for decades, that we use, what's called CCISC, and this was originally developed more than 20 years ago in a project I chaired for SAMHSA on developing managed care systems for people with co-occurring mental health and substance disorders. But since then, we've taken this and worked with so many systems with more and more complex issues and more complex systems. And there are things that we've learned along the way that come from all of that research and how to apply that research in real systems. So first of all, every part of the system becomes, so a simple way of saying it is every program is in the complexity business. Every program is a co-occurring program. All systems, processes, and programs become welcoming, hopeful, strength-based, which is a way of talking about recovery or resiliency-oriented, trauma-informed, and what we call co-occurring or complexity capable, which is responsive to people with every kind of complex need who show up at the door. Not only every program, every person providing care. And we call this a 12-step program of recovery for systems, because the idea of how systems get from where they are to where they might want to be requires that same kind of step-by-step structure using organizational processes that individuals with overwhelmed lives might use to get their lives back together after they've been deluged with addiction and serious mental illness and serious health conditions and so forth. So what do we mean by a program becoming complexity capable? Well, for those of you who run programs, think about it this way. If back in the beginning of time when your program was first developed, and this could be whether it's a mental health program or a substance program or a health program or a housing program or whatever, okay, and whether it serves adults or kids or people of any age and whatever their cultural backgrounds might be, you say to yourself, if at the beginning of time when our program was first invented by the people in our system who design things, if they knew then what we know now about the complexity of the people we're serving, and if they knew then what is known now about how to be helpful and hopeful to those people in an integrated fashion within what we do, how would we have designed everything about our program that makes us our program on that assumption that the next person we see is going to have complex needs, and we need to be in the business of helping them exactly as they are? And by everything that makes our program, I'm talking about organizational design, policies, procedures, practice, paperwork, competencies, so that instead of designing our programs for simple people and then having to put extra effort into people who have any kind of complexity, we design our system first around the expectation of complexity for the people we serve. And then if we get people who have fewer problems, well, that's so much easier. Now, every program is in the complexity business, but as you know, in a system, every program has a different job. And the job is defined by what it sets out to do. Is it doing adult case management for people with severe mental illness? Is it healthcare for the homeless intervention? Is it a primary pediatric practice? Is it school-based outreach for kids with emotional disturbance, residential substance for pregnant parent women, whatever? And the people who are showing up at that door for whatever reasons that bring them there, bringing all of their complexity with them. Not only every program, every person providing help. So I'm not saying here that everybody has to go out and get multiple degrees and licenses. It's actually way less complicated than that. The idea is that every person, regardless of how many degrees or licenses they do or don't have, needs to have specific instructions within their job at their level of training, whether they're a peer support person, a medical assistant, an overnight residential staff in a group home for people with intellectual disabilities, to know how to be helpful and hopeful in addressing the actual needs of the people who are sitting in front of them. And paradoxically, when we do this, the less formal training that people have, the easier it is for them to understand what to do when they encounter people with complex needs, provided they're given reasonably good instructions and the right set of supports within which to do their jobs. Now, we have a set of tools I'm not going to go into for how programs can self-assess of different kinds, behavioral health and intellectual disability and health and prevention, and system of care partnership tools for children and adults and so forth, leadership tools and tools for staff and all this kind of stuff. Now, here's the final core value for this, okay? As I said earlier, is that in any program or organization can make progress thinking about this, whether anybody else in their community does or not, because you have capacity to improve service to your own people on your own, within your own resource. But in a community, you want to come together around the idea that everybody in our community is held responsible by us. And each of us will step forward to say, no one is going to fall through the cracks. So every component of the system takes accountability for its population. We make sure that no one falls through the cracks, and we all hold each other's back, so that those of us who've taken a risk working with some particularly challenging people know that they're not in it on their own. And this is another radical idea. When we're designing systems, and we're increasingly doing this work all over the country for all different kinds of systems, crisis systems in particular, we have to stop thinking that responsibility for people with complex needs belongs only to one funding stream. It's a state job, it's a Medicaid job. No, it has to be a collective responsibility, just like we think of for roads and law enforcement and other essential services. It's public payers, private payers, state payers, local payers. Everybody's in this. And the better that we bring all the partners together to support what we're trying to do, so that each funding stream is supporting complexity at the other end, the less burdensome it is for any single funding stream to figure out how to do this. Okay. So here's the second part. Now that we have this vision of what we might like to achieve, what do we do? How do we do this? How do we think about this? So there are a couple of things in this section that I want to emphasize, because there are some do's and don'ts. So first of all, changing the system is not something that happens only in one place. A lot of people say things like, hey, look, our state is integrated because the mental health department and the substance department now call themselves behavioral health. Well, that doesn't really change anything except this letterhead, okay? That doesn't produce anything out the other end. Or a lot of systems are currently saying that, oh, we're integrating health and behavioral health because, look, we're contracting with managed care companies that if we give them all the money, they promise to do good things with it. That doesn't work either. Thinking about how to do this in a system means we have to look at all of the levels of the system. And every system, Colorado, wherever you are, is sets of nesting Russian dolls that are not quite so nesting, systems within systems sitting next to other systems within systems. And the goal of transformation is to lay out a set of values and processes and practices and say, how do we engage so that every system, subsystem, sub-subsystem is moving in a common process to achieve this common vision around the people with complexity that we're serving with every resource that we have. Okay, in a provider agency, that means the agency as a whole, each program within that agency, and each person delivering care is working toward a common vision. In a community, it means all the provider agencies are coming together under an auspice to do just that, and so forth. So who's responsible in a county or a region? So if I'm the state of Colorado rolling out a blueprint, I'm thinking, so who's going to help make this blueprint happen at the intermediary level? So I'm looking around and saying, where's the regional or county level interagency coordination capacity in my system? And how do they partner at the local level with collaborations for population management? For many county public health or behavioral health departments may take a lead role in facilitating these collaborative activities. So each state has intermediary structures. It's very interesting. I mean, I've worked in just about every state doing consultation. And even though we're all the United States, every state is different in the way it sets up its intermediary structures. So, but it's nice for a state to work with what it has, and to, given that some states have very weak intermediate structures, to try to figure out how to strengthen those structures so they're more functional. Otherwise, you're constantly running in circles, not being able to use your resources very well. And here's some examples of the kinds of things that could be intermediary structures: county departments, large providers that have catchment area priority responsibilities, circuits that are organized around court jurisdictions, city departments, community organizations, are all things within regions or counties. And at the state level, there can be managing entities, like in Florida. There can be designated catchment areas that are assigned according to local mental health authorities, like in Texas, or community services boards, like in a number of states, and so on. And then within the local structures, within those intermediaries, you're looking for a collaborative structure that brings all the partners together, or at least as many partners as will initially show up, developing a consensus, identifying everybody's got their population, so let's be accountable for who we're serving, some capacity to coordinate across things, and then working toward universal complexity capability in a framework of data-driven population health management and improvement. Okay, so the next question is, how do we go about bringing everybody together within this design collaboration to say, what are we going to do? How do we get busy? Okay, so this asks, what do regional or local systems do to support the transformation activities of all the participating partners? Okay, so so counties, for example, if you're a county health or behavioral health leader, you can create a county level interagency strategic planning based on the idea that we're going to improve our overall capacity to work with people with complexity in our county. We can bring our mental health providers, our addiction providers, our health systems, our human service providers. Everybody can sit around the table creating a collective vision. If we're in a large county, it might default to something local, communities within the county. Or if it's a multi-county region, you might do things all together, or you might break up into county-specific activities for certain things based on your structure. But it's important to pay attention to using your strength and capacity to get everybody together, as many people as you can, and say, let's figure out what we're going to do. Now, there's a whole bunch of things you can do. The thing that I highlighted here, and they're all interactive, is universal complexity capability or universal behavioral health or health integration. They're overlapping things. And there's a whole bunch of stuff here, but I'm going to move into something simple. So when you say every program is going to be co-occurring or complexity capable, how do you do that? So one of the things that we've learned over the years, and I learned it when we did the original SAMHSA project back when, is that there's a tendency to want to go out and find the special research program or the special this or the special that, so that every special subpopulation has another special program with extra effort and extra resource. And you know, we can't do that. There's just too many people. And most of the time, they don't, even if we had a special program, they wouldn't go. So what we've learned by looking at the research is to unpack the research. This is a bit of an art. And to look inside and say, what is it that happens inside a program that's helpful to people? And how do we find the practices and interventions that work for people with co-occurring and complex needs, and begin to apply them as routine features in any program? And so out of that work over many years, we've learned a very important thing. The more complicated things are, the more important it is to use very simple principles and interventions to ground the change process and to help people. And we in the helping field, we get so good at complicated jargon and all kinds of academic overkill that we don't understand ourselves half the time, let alone the people that we're trying to serve. So there are 6 very basic principles, which I'm going to review quickly, that have interventions attached that can be developed in any setting that create practice improvement opportunities within your community collaborative so that everybody can start making progress right from the get-go. Or you can do it in your own organization, even if nobody else in your community is doing it. And so here are the 6 principles made simple. Okay. Welcome people with complexity as an expectation. So this idea of welcoming is not just about being nice. This is built on a philosophy or a practice or a technology we all are familiar with called customer service, where everybody gets specific training, instruction, prioritization, and there's ways of measuring the success of this, not just for the simple customers, but for the people we know are complicated because they are identified as priorities for engagement. So things like basic welcoming. Hi there, you're one of those folks who has lots of needs. It looks like you're hearing voices and it smells like you've been drinking just to get up the nerve to come here. You have all these physical problems. You're in trouble with the law. You just lost your housing. Your family wants nothing to do with you. You know, you're the kind of person we most need to be helping here because you're the kind of person who's having the hardest time. We know it couldn't have been easy for you to show up here asking for help. Thank you for coming. You're in the right place. We're really, really glad you're here. We know that our job when we meet you is not to fix you, perfect you, refer you, control you. Our job is to get to know you, inspire you with hope, and help you get connected to us and anyone we might find along the way to help you with all your issues so you can have a beautiful life. Now, there's nothing in that speech that's rocket science. The question we ask is how well organized are we at every level to be able to deliver that message by policy, procedure, and practice when people show up at any door in our community. What are we welcoming people into? Well, first of all, we're welcoming the opportunity in addition to identify all their issues. Even though we know we may not be able to fix them and we may in our own organization not have specific resources to address them, we want to identify them, we want to count them, we want to document them, and we want to indicate that we're helping people with all of their issues to go forward. If we're not counting you and reflecting your complexity in our data, it's because we've organized our counting as if you didn't count. Then, once we welcome and identify, our next job is not to refer you all over the map because it was amazing you even showed up at our door. So we want to engage you in a relationship right here, right now, for as long as it makes sense. And the relationship is empathic and hopeful, integrated and strength-based. And we work with you in small steps over time with each of your issues so that you can make successful progress. Hope means we help you identify your most important goals for a happy life and document that. We also recognize all the amazing things that you've already been doing right to make progress instead of finding all the things you're doing wrong. And recognize that in the land of strength-based, everything is built around strength. So there's no such thing as a chronic relapser. There are only people like us who are recurrently successful. Third, we recognize in the complexity business that we are all in it, but we all have different jobs. People with different combinations of needs are not the same. They show up at different doors for a variety of different reasons. And every part of the system has its job with the population of people that are going to show up there and get attached there. And part of our job is not only helping our own complexity people, but helping everybody else do their job effectively. So more people get what they need in a single door and fewer people fall through the cracks or need duplicate services. And we help everyone by consultation and in-reach. So because it's easier for staff to move around to where the people are so that the people don't have to as much as possible. And a well-integrated system has fewer referrals and fewer multiple registrations because it's easier for people to get what they need that way. The best practice for people with multiple issues is for each person to receive the best practice next step intervention for each issue at the same time, much as we do our own lives. For disorders, that can be medication and psychosocial intervention. For things like housing and criminal justice, there are psychosocial interventions. But the issue is you identify each of the person's issues, you help them figure out their next small step forward, make it simple enough so that they feel successful, as do we, and don't expect everybody to get fixed overnight. We match interventions based on stage of change for each issue because everybody moves through stages of change: pre-contemplation, contemplation, preparation, early action, late action, maintenance. But most people are not in the same stage for every issue at the same time, just like we're not. So if somebody says, what stage is a person in? The correct answer is for which issue. And then when we're helping people, we're not just giving them recommendations, referrals, lists of things. We're actually helping them in small steps, learn, practice, role play, the skills they need to manage themselves, to ask for help for each issue in very small steps over time. So it all becomes much simpler, and there's more detail about each of these principles as we go. But this is the summary. Okay, so you're bringing people together in a community collaborative. Every part of the system, every partner can start making progress inside what I call the serenity prayer of change, even if nobody else does. Okay, so everybody can make small steps. And the collaborative is not about let's come together to apply for a grant, let's come together to blend our resources, let's come together to make something super complicated, but let's come together to create kind of a local recovery support meeting for system change, where all of us improve our ability to work with our complex people, and all of us get better at asking for help from others and helping others, so that more people get what they need in our system within the doors and resources that we have. And our goal is that everybody in our community who, with complexity as an expectation, is welcomed into the door that's most sensible for them, into relationships that are empathic, hopeful, ongoing, recovery and support partnerships in which they get help with multiple issues, and they get adequately supported, positively rewarded, strength-based, skill-based, stage-matched, community-based learning for each issue, so that every individual and family in our system, within the resources that we have and structures that we have, can get help to move toward the goal of a happy, meaningful, successful life that they're all capable of achieving and deserve to get. Thank you very much. I hope this is helpful to you, and there are more slides for you all to look at that will be available to you after the presentation. So now hi Jen.
Hi Ken, you have a question from the audience, and we have time for one question if you're willing.
We do. Oh, how good. Okay, that's a miracle.
says, hello, Ken. This is very well put. Would you say that provider self-care, building in time to spend with family, support systems, time off, training, is important in the path to providing person-centered care where others feel welcomed?
Yes, I do feel that provider self-care is important, but I also, part of the emphasis here, which I didn't get into, is that, just because I didn't have enough time, but there's an organizational change process. The recovery process for organizations involves what I call continuous, customer-oriented continuous quality improvement. And part of that process involves the organization attending to internal and external customers. And the internal customers include creating purposeful empowerment and engagement of frontline staff as change agents and champions working in partnership with leadership to overthrow the established order to create a more welcoming and trauma-informed environment for everybody. So you have to use best practice organizational change strategies to do this. And when you do, you realize that a lot of the burnout that people experience is not inherent in doing this work. It's because we're put out to try to be helpful to people. And what's in our heart is to be helpful. And we're working within structures that actually encourage us frequently to do exactly the opposite of what would be most helpful for the people in front of us. So we feel squeezed. When we get empowered in our organizations to work collectively to improve welcoming and hope as part of what we're delivering, the work that we came to do starts to become rewarding the way it should be. And the level of burnout tends to get less because we're experiencing more empowerment and safety as part of our job and more ability to contribute to the organizational culture, both individually within our programs and organizations and collectively within our communities. So doing change only from the top down is a mistake. For leaders to do change to their staff is a bigger mistake. Engage your staff as partners, just as you would want to engage people in service as partners, and empower everybody to figure out how to work toward this direction within what I call the serenity prayer of change. The serenity to accept the things you cannot change, which is everybody else. The courage to change the things you can, your own work, your own team, your own program, your organization, your community, and the wisdom to know the difference.
Okay, thank you, Ken, so much for that fabulous talk. You gave us a lot to think about. So next we're going to move to Lieutenant Governor Diane Primavera has provided a video with some remarks on the most recent Colorado Behavioral Health Task Force blueprint.
Thank you, Dr. Ken Minkoff, for the introduction and for the wonderful presentation. I would also like to thank Dr. Jen Leiferman, the Population Mental Health and Wellbeing Program, the Rocky Mountain Prevention Research Center at the Colorado School of Public Health, and affiliated partners at Anschutz Medical Campus for hosting this event. I'm glad to be able to join you all. Many of us have witnessed and have been personally impacted by behavioral health challenges in Colorado. Some of you may already know my story. I've committed my career to ensuring equitable, affordable, accessible, and quality health care for all Coloradoans. As a 4-time cancer survivor, I felt like I'd been given the gift of life back, but I also experienced significant emotional and financial challenges during my treatment. As a result, I wanted to fight on behalf of others who are facing the same challenges I once did. So now, as Lieutenant Governor of Colorado, I've made healthcare one of my key priorities, especially lowering the cost of healthcare for all Coloradoans. Our system needs to change. That's why addressing behavioral health challenges has also been a key priority for me and the governor. From creating the Office of Saving People Money on Healthcare to creating the Behavioral Health Task Force and implementing its recommendations, we are taking important steps to make our healthcare system more equitable, accessible, affordable, and responsive to the unique needs of Coloradoans. Behavioral health issues have been a major public health concern in Colorado for years. devastating families, and tearing at the fabric of our communities. Unfortunately, as in other realms, the pandemic has only exacerbated these concerns and exposed underlying inequities that worsen health disparities in many communities, marginalized by a history of systemic oppression and discrimination in this country. We also know that a lack of affordable health coverage and high out-of-pocket costs are major concerns that impact a person's willingness and ability to access needed care. It's also clear that certain populations are disproportionately impacted by lack of access to behavioral health services. Coloradoans with lower incomes and without insurance, people of color, adults in their 30s and 40s, and women report particularly high levels of vulnerability. Access to behavioral health care is also particularly challenging in rural areas. More than half of rural counties don't have an active licensed addiction counselor. And lastly, but perhaps most importantly, access to care is overly complicated. Currently, navigating care for some can be a Byzantine complex, a process spread across no less than 10 state agencies and over 75 different programs. At the end of the day, all this means that too many Coloradoans are slipping through the cracks and aren't getting the care that they need. We can and must do more. So in the spring of 2019, the governor created the Behavioral Health Task Force to boldly reimagine how we deliver mental health and substance use care to Coloradoans. We brought together more than 100 providers, local and state leaders, consumers, and advocates to design a system that puts people first. And just last month, the task force released a blueprint with recommendations. Through my personal experience as a member of the task force's executive committee, I know that we can work together to better serve Coloradans. The task force set forth a bold, achievable vision for making behavioral health care in Colorado more equitable, efficient, and accessible through the creation of a behavioral health administration. Care coordination will help patients and providers better navigate the resources that are available to them, including those that fall outside of traditional health systems, such as housing and food assistance. This structure will also allow local communities to design care that best works for them. The blueprint reimagines behavioral health care in our state. No longer should Coloradoans adapt to a complex bureaucratic system. Instead, the system should adapt to the unique needs of each Coloradoan. This will allow us to help more people and ultimately save more lives. By putting people first, we can focus on getting them the critical care that they need. So in conclusion, the governor and I are working closely with the task force, stakeholders, and the state legislature to implement these changes. I want to make sure that everyone has heard that the recommendations put forth must and will be implemented. Looking ahead, we must all work together to revolutionize how we deliver behavioral health care in Colorado. We need to put people first. By working together, we can continue to help people get the care that they need. So I'm excited to see you all participating in this year's conference. It's through forums like these that we can continue improving behavioral health care in Colorado. So thank you for having me today and for your continued commitment to behavioral health.
Okay, thank you. That was a great video and follows up on the recently released blueprint for Colorado. We'd like to move into our panel. First, I just want to introduce myself. I'm Jen Leiferman, the director of the Rocky Mountain Prevention Research Center here at the Colorado School of Public Health. And we have a great panel of leaders here in Colorado who are going to share the work they're doing related to population mental health and its impact on our population. So we have 4 speakers. They'll go consecutively, and then at the end we'll have time for a question and answer period. So our first 2 speakers, Dr. Carl Clark and Dr. Wes Williams, are from the Mental Health Center of Denver. They'll speak first, then they'll be followed by Dr. Sarah Nagel-Yang from the University of Colorado Department of Psychiatry here at Anschutz Medical Campus. And last will be Vincent Atchity from Mental Health Colorado, who will share recent policy work for the state. So Carl, would you like to go first?
I would, thank you. So, can you see my screen?
Yes.
Okay, great. So I'm Dr. Carl Clark. I'm the president and CEO of the Mental Health Center of Denver. And at the Mental Health Center, we focus on what people are good at, on people's strengths. These happen to be some of my strengths that you see here. And we know that communities have strengths also. So in January of 2016, the Mental Health Center of Denver opened the Dahlia campus for health and well-being. We're taking a new approach to community well-being by providing whole person care for mind, body, and community. And our original thought is that this campus would be about a 20,000 square foot clinic with mental health services. But the community informed us what they really needed in that community. And one of the big focuses was food. So there was the concept of a food desert, which is lack of access to food, but also the concept of food swamp, which is access to really bad food. So the community made a big emphasis on they needed food to be a part of this. So that evolved to other things that would help the community thrive. So we have the urban farm, aquaponics greenhouse that grows vegetables and fish. We have a community garden that the community can be active in. We have a teaching kitchen that talks about, how do you prepare food in healthy sorts of ways. We certainly have our mental health services, but we have a lot of community spaces too. So we have a gym, that the community uses. We have a preschool, a school, and then we heard from the community that access to pediatric dental care was important. So as we were meeting with the community, they made these issues alive for us. Lack of housing, lack of employment, lack of education, and just the impact of poverty. So we have programs called To Succeed in Education and To Succeed in Employment that help people go back to school and go back to work, and another program that helps develop affordable housing. Now, we didn't start off in a very easy way. When we got this property that had been the largest African American owned strip mall in the past, 20 years ago, it burned down. Many people had purchased this 4 acres of land with promises, and the community had doubts because of how many promises had been broken. The community said to us, we're poor, we're ethnic minorities, and Mental Health Center of Denver, that sounds like you're going to move people into our neighborhood that we don't want here. But having these conversations over and over, move that conversation to saying, oh, you want to build a place for somebody like me. And when that engagement happened, we got deeply into the types of things that would help this community thrive. So our sharpest critics actually turned into some of our closest allies as we developed the campus. They care deeply about this community, and we're honored that we got to co-create with them. The very first year, this is actually the gym, we had 6,000 people use the campus. The way we set it up was if you had something to offer the community in the facility and it was offered for free, we made it available to the community for free. If people were wanting to charge for it, we charged a small facility fee. So that it has been greatly successful, and we're quite happy with the way that turned out. We have other programs that are involved with the community. Our co-responder program is where licensed social workers go out with police officers on calls that they believe will have some behavioral health component. That's either someone dealing with mental illness or some type of addiction. Started off as a pilot with 6 social workers, and within 6 months, every police department was asking us for co-responders to join their district. Our newest program is the STAR program, and this is where some 911 calls actually come to us. And the STAR program has a paramedic and a licensed social worker that goes out in this van, and they meet people to see what they need and get them access to what will be helpful to them. It's had a lot of support. People like the idea that not every 911 call requires armed intervention. So we're looking to grow that program. And then meeting people where there are is where we're talking about our digital front doors. So Wes, I'm going to let you take it from here.
Great, thanks, Carl. Appreciate the introduction. Here, let me share my screen here. And are folks seeing the application, or are they seeing the slideshow view?
Slideshow.
Slideshow.
The application, not slideshow.
All right, one moment here. That's the drawback of being Chief Information Officer. You can never blame anyone else for the technology problems.
Wes, I have your slides if you want me to show them.
No, I've got them right here. I
Okay.
just need to get it to the right spot, which is tricky because I'm juggling 3 applications on 3 screens, but I think I've got it right here. All right, hi everyone, I'm Wes Williams. I'm the Chief Information Officer at the Mental Health Center of Denver. And what I'd like to talk to you about is our digital front door, right? So we started working on this about 2 years ago, thinking about where we wanted to move as an organization, and specifically for me, how technology might help us get there. Here's part of, one of the reasons for this is I think that behavioral health has a critical access problem in terms of people who need help not receiving it, right? So let's look at Denver as an example, right? So we know that about 1 in 5 people have a behavioral health condition that could benefit from treatment, right? So that's 144,000 people in Denver. Mental Health Center of Denver saw about 20,000 people last year, and another 40,000 were treated by another provider, which leaves 86,000 people not being seen who could have benefited from help. Right? So when we look at this, here's the challenge. We saw just 1/5 of the people we needed to see to solve the behavioral health access problem in Denver. And so one of the questions we asked is, how might we use technology as a force multiplier, leveraging technology to deliver something to people who weren't getting anything at all, right? So we started out looking at a digital front door, and we did a bunch of sort of human-centered design research, initially focusing on population from age 16 to 25, asking the question, how might we give people the help they need before we ever see them face to face? And what we came up with was sort of a combination of services. This summer, we released a telehealth app, making it easier for folks in treatment to launch their services via telehealth just from a couple clicks of a button, right? But this fall, we are also launching You at Your Best. It's a partnership with Grit Digital Health, where we are offering sort of curated behavioral health resources to the people we serve. And what that will look like is a combination of both digital resources, right? Informational videos and self-assessments and things like that, as well as localized content around where people can go to help in their community, right? With sort of traditional brick and mortar providers. And we think this combination is really the future of telehealth, right? Where we can both connect people with more traditional resources as well as deliver to them what they need digitally. All right, so that is it.
Okay, thanks, Wes. Sarah, would you like to share your slides?
Sure. Okay, are you seeing my slides?
Yep.
Okay, let me just, sorry, 1 second here, get it so that I could see it a little better. That will be helpful. Okay, hi everyone. My name is Sarah Nagel Yang. I am a reproductive psychiatrist with the Department of Psychiatry at the School of Medicine, and I'm pleased to be here today to share with you the Colorado Center for Women's Behavioral Health and Wellness. So the center is a relatively new resource of the School of Medicine. It was started in 2018 when Dr. Neil Epperson became the chair of the department. And the goal is to provide the highest quality mental health care to women across the Rocky Mountain region. Many of you may already know that Dr. Epperson is internationally known for her clinical and research work in women's mental health. And so this is obviously an area that's near and dear to her heart and a real priority for the School of Medicine as well. The Colorado Center has 4 pillars. So I'm going to highlight mostly the clinical services today, but to put that into context, there are also faculty and resources devoted to research and clinical trials, education and training, and policy and advocacy. Within each of these pillars, there's sort of these domains that really represent the domains within women's mental health. So when we think about women's mental health, we really are thinking about specifically mental health conditions that present or arise during times of reproductive transition. So a lot of our services are dedicated to perinatal mental health, but we also have services related to the relationship between mood and menses, behavioral health considerations that arise during perimenopause, such as mood concerns, sleep and sexual health concerns, and then medical conditions and their treatments that come along with reproductive hormone transition. So this could be particular treatments for breast cancer, for example, or medical conditions such as PCOS. So while the Colorado Center is based within the School of Medicine, our services span several different settings, including Children's Hospital, University Hospital, services within the School of Medicine, and several outpatient offices across the Metro Denver region. Oops. Excuse me. And, in terms of, our goal of increasing access to high quality care, currently we're doing so through a variety of mechanisms. And so we have an outpatient service that's available to women across the state of Colorado via telehealth, including via telehealth. We have integrated services, which I'll highlight in a moment, and then services that are focused on wellness and prevention. This is, again, to highlight some of the various types of integrated care settings that we are involved with. So on the left-hand side, you'll see a number of integrated care sites focused on perinatal mental health, and these span, services such as OB/GYN clinics, pediatrics clinics, Warm Connections is within a WIC office, and then the Connections program exists on the inpatient OB/GYN service and also the NICU setting. On the right-hand side, you'll see services that span the sort of the realm of women's mental health settings. So we have women's health primary care settings, general and specialty GYN, menopause clinic, a sexual health consult service, and a presence at the breast center as well. Also highlight that within some of these settings, we're piloting a specialty e-consult or e-collaboration service for provider to provider direct consultation over electronic medical record. This is just a highlight of one of our prevention focused services. So this is the Apart But Not Alone group, which is a wellness group for perinatal women specifically during COVID-19. This is a group that's free of charge, offered virtually, not meant to be a treatment group, not specifically for women who have concerns about their mood, but really as a way to foster connection as a protective factor during this global pandemic. And, all of these slides so far have really kind of outlined our organizational structure and, what we're doing in the moment. I wanted to make sure and have a slide in here to illustrate the fact that this is really a beginning. We're a new center and we have a lot of goals moving forward. And I'll just highlight a couple of those here. So really at the center, in order to increase access to mental health services for women across the state, we believe a critical component of that is provider education, with the goal in mind that, whether a woman identifies her, her birth doula, her lactation consultant, or her gynecologic oncologist as the person that she feels comfortable, talking to about her mental health concerns, that each of those providers has an awareness of women's health concerns or mental health concerns and has had enough exposure to the resources available that that person can make an appropriate level of assessment and a referral to appropriate services. Particularly in the realm of perinatal mental health, I'll say that our services are wide and varied and across all these systems of care, which adds a layer of complexity that makes it actually really challenging in the moment to navigate through all of these resources and find the right level and the right type of treatment for each person. And so one of our really immediate goals is to develop a single point of access for all of our perinatal mental health services so that we don't put the burden on the patient or the referring provider to navigate the complex system that we have. Also, as we grow, we will do so with an intentional focus on equitable access to clinical services across the state. We are aware that even now, when we're able to offer most of our services completely virtually, we're available to women across the state of Colorado, but the majority of our patients still come from the Metro Denver region. And so we really want to focus on, fostering relationships with providers in rural and frontier areas where there is obviously a great need. We also know that communities of color have been disproportionately impacted by the COVID-19 pandemic and by the health effects of racism as well. And so as we grow, really maintaining and fostering relationships with organizations and providers who take care of populations who have been historically marginalized is a priority for our center. And finally, while we have a wealth of kind of services already, we also understand that there's still work to do, particularly in terms of access to more intensive level of services for our Colorado women, and particularly probably perinatal women. And so one of our more immediate term goals might be something like a partial hospital program or intensive outpatient program designed to really fit the needs of our perinatal patients. So that is a bit of a whirlwind. I will put up our contact information here and invite everybody to please reach out to us with questions, with referrals, for ideas. We want to be a resource for the region, and so please let us know how we can best do that.
Great, thank you, Sarah. Vincent, would you like to share a few remarks?
Yes, thank you. I will try and share my screen here. So if that's working, can you hear me?
Yep, I can hear you. We can see your slides.
Great, thank you. Thanks so much for having me. I'm Vincent Atchity. Just going to talk a little bit about our work. We were founded in 1953. We are the state's leading advocacy organization for mental health. Most of our work is focused on changing laws, and therefore we do a lot of public education as well as education of elected officials and state leaders. We're also interested in supporting efforts to change practices in order to yield better population health outcomes. One of our key areas of activity is just sort of raising the general awareness about mental health and the understanding that Too often people confront mental health needs in times of crises and then find that they have to discover the challenges that have been described over the course of the morning when it comes to accessing quality care that really takes into all of those complexities that Dr. Minkoff was describing. So what we've been trying to work on is getting people to understand that mental health, like physical health, is something that we all have. We have it from one end of our lives to another. Nobody experiences perfect mental health from one end of life to another. And any of us can find ourselves in a time of crisis where we need to access that kind of care. As with physical health, we understand that a lot of our needs are not actually based on access to care, but rather the sorts of environments in which we find ourselves trying to develop our healthier minds and keep them healthy across our lifespan. So we've been promoting this understanding that it's really a lifespan thing, and a really important place for us to invest our time and energy as a community is in providing a strong start for children. This is true with mental health as it is with physical health. Those formative years are so key in terms of long-term outcomes. And then we're also concerned about wellness and aging, which begins as soon as you're born, essentially, but is particularly a concern as one approaches the end of life and experiences isolation, loneliness, as well as all of the sorts of instabilities that are particularly concerning to us in our country, where we age into concerns about accessing healthcare, retaining our housing, having financial stability, things like that. And along the way with that lifespan, we've got this major issue in the middle, which is where we almost systematically make matters worse. And that's when we can't access quality healthcare in our times of crisis. What we instead find is that we are cycled into engagement with the justice system. And so we're really zeroing in on these three areas this year for our legislative and advocacy work: the strong start for all children, the wellness and aging, that lifespan continuum of supports that are essential, and then really driving home this message of care, not cuffs. When we call for help, we need help. We don't need harm. We should have the same kind of response to a mental health crisis that we have for a stroke or a heart attack. It should not end in handcuffs and transport by a police car. We really applaud for, in that way, the work that Mental Health Center of Denver has done with their co-responder and their STAR program. Those are exemplary care, not cuffs efforts as we see it. And then just this final point that, even as we look at this strong start for our children, much of our work this morning and much of our work as members of the Behavioral Health Task Force in the state have been focused on this blue section of a pie of health, which is all about healthcare access and interventions. And what we know from our public health understanding of things is that where we really need to work is in the orange section over here on the left. And these are the places where we are consistently weak as a community in terms of providing stability of affordable housing, high quality education, food security, supporting families, and contributing to strong social networks, and contributing to a community in which people, especially people of color and other vulnerable communities, where they feel safe and secure and feel that they have an economic future. We fall so far flat on so many of these things that we drive huge volumes of need toward an overburdened healthcare system that then shrugs people off into a criminal justice system that does none of us any good. Our legislative priorities are on our website, mentalhealthcolorado.org. We identify policy work along the entire lifespan continuum, and we drive our grassroots network of advocates to contact elected officials to help make those policy changes happen. So I'll cut it short there.
Thanks, Vincent. That was great. So now we have time for question and answer. I see we have one question. Feel free to put your questions in the chat box there. Our panelists have agreed to stay on a little later today. If you all would like to stay on and ask further questions beyond the 11:30 time. And just a little bit of housekeeping before we start the Q&A. We will have a Flipgrid session from 11:30 to 12:30 where you can go and view the student presentations as well as the COVID related work. And then our afternoon sessions will start at 12:30 on health equity, integrative care, ACEs and early prevention, and I'm blanking on the last one, mental health and technology. So we hope that you can attend the afternoon sessions. So I'll kick off our questions here. We have one in the chat box. And the first question is, it seems we will never be able to scale service delivery to meet the vast needs through one-on-one treatment. What opportunities do you see for population level prevention rather than treatment of mental health challenges? So I open that up to our panelists.
So first of all, there's more to health than the absence of illness, which is why many behavioral health providers are incorporating the science of well-being and positive psychology into their work. There are lots of things that can be done that frankly don't require a therapist. And if we look at therapists across the planet, there is one therapist for every 10,000 people that need help. We cannot solve this access to care issue by merely getting more therapists. It's not going to happen. So what are those curated resources that we can put together where people can get help even before they see a therapist? And that's part of the concept behind the app that we developed.
I can chime in and just say that when it comes to prevention rather than treatment, there's a key ballot initiative on the ballot right now for paid family leave. Providing paid family leave is an essential way of providing a strong start for all children by creating that kind of a supportive family environment and making it possible for parents to contribute to a child's early development during critical months. In the bigger picture, we should be promoting things like universal access to childcare. We should be promoting a living wage. We should be working hard to create more affordable and supportive housing. These are the kinds of essential supports that many of the nations that I think of as the more developed nations have put in place and go far toward contributing to healthier minds across the lifespan.
Great. I have another question for our panelists. How has your work changed since COVID? How has COVID impacted our population mental health efforts recently here in the state of Colorado?
Well, so I can say a little brief something on this. It radically shifted how we did work. Our workforce shifted to a telecommuting workforce from one that was basically 100% in person, and maybe 90% of our services shifted to telehealth and telehealth service delivery. In addition, we really thought about the priorities of our innovation lab and the kinds of things we wanted to focus on in terms of technology and mental health. We had a fairly significant stream in partnership with the National Mental Health Innovation Center here at Anschutz, and that was mostly focused on virtual reality and bringing that in. And since that's sort of a hardware dependent intervention, we had to back burner that, but we've taken those resources and more and invested them not just in traditional telehealth, like one-on-one video sessions, but in this digital front door more broadly, thinking about how might we help people with lighter touches and reach sort of substantially more folks.
I could also add, I mean, in the Department of Psychiatry, we also very rapidly converted our work to almost exclusively via telehealth, which has been a huge and very fast adaptation. And I'll say that, you know, in my personal experience with the work that I do, I mean, I've been very much encouraged by how much more accessible it feels to many of the patients that I've been working with. You know, they're able to join from their living rooms, which also has its challenges, especially when we're thinking about women with young children or in situations where they may not feel safe at home. And so it's sort of brought this whole host of learning opportunities and you know, real, you know, careful considerations in terms of the work that we're doing. I'll also say that it's been very concerning, you know, as a part of an academic and a hospital culture, to think about our frontline healthcare workers, of course, and how sort of disproportionately some people are being impacted by the trauma and the stress of the pandemic, you know, from their daily lives. And so that's been a focus of the department as well.
Thanks, Sarah. We have a few more questions here. The next question is, along those lines, are any of the organizations represented working with peer-to-peer groups for social support? How does social support help to increase access to behavioral health?
Yeah, we've used peer mentors for the past 25 years. So, and there is a difference when somebody has the lived experience of having dealt with an illness, of being able to be that bridge to treatment and to talk about sort of the, you know, personal, you know, sort of journey that people can have when they're trying to seek help. And so we've had a system in Colorado that has allowed payment for this. It's sort of being threatened a little bit right now with the current payment structure. And we're trying to advocate for that flexibility to remain in the payment system.
I will add that we also have actually just last month kicked off a pilot program funded by Colorado's Office of eHealth Innovation through one of the Innovation Response grants for telehealth. This is a partnership with a company called Meru Health that has people taking sort of self-paced cognitive behavioral treatment for depression, a 12-week course that people take online, but there's a significant peer component to it where people go through the groups in cohorts of 10 to 12 people receiving the treatment, and there's sort of a peer-to-peer chat component that's moderated by a therapist. And I think one of the things we think is important to prove out there is that the peer-to-peer chat and the therapist moderation can solve the problem that Carl was mentioning earlier around, you know, there just are not enough therapists in the world to go around. So how can those therapists do lighter touches and still be helpful?
With regard to peers, we passed a year or so ago a piece of legislation to establish psychiatric advance directives. And those are now available for people to use so that they can designate the sorts of preferences that they have for psychiatric care in times of crisis, just as we have sort of medical powers of attorney in the case of medical crises. And we're using peers to guide people in the formulation of those psychiatric advance directives. We're also working with training peers in the context of the Department of Corrections to provide support for each other within corrections and as they transition into the community upon release in a bridge, sort of a peer-led bridge program.
Thank you all. Our next question, do you have ongoing work with the educational system, including a focus on healthy social emotional development, as well as access to school-based care?
Well, the short answer is yes. The more complicated part of the answer is COVID-19, right? So every school has their own sort of plan about how much is in person, how much is remote. It kind of shifts back and forth. And our school-based clinicians that have been embedded in the schools are having to connect with people, frankly, remotely. And we certainly know the benefits that kids get with being able to be social with one another. And I think that's a challenge for all parents right now about how can you do this in a way that keeps your children healthy and safe.
Okay, it looks like we have one last question. Many of the work you all do overlap, which is great. How is the state of collaboration and coordination between all the organizations and institutions doing similar work across regions in Colorado? Do CEOs and CIOs get together? Do staff get together to share vision?
So in Colorado, we have something that's a bit unique compared to other states. The community mental health centers kept their original catchment areas that were established 30 years ago by the feds. And we have the Colorado Behavioral Health Care Council. So yes, in fact, we all do get together. And our goal is how do we improve access to care for each region of the state. We happen to be the only healthcare group in Colorado that covers the entire state. So that's a big part of the work that we do. Now, we're not the only groups that provide care. There's also, hospitals and private practitioners. And I would say the conversations with those groups don't happen as often, which is what we're encouraged by about having a behavioral health authority in Colorado, which is what it came out of the task force. We like that concept.
And at the Nima, to answer your question, at the CIO level, there's a group called C4 that is hospital and other healthcare CIOs that meets every other month and has been sharing sort of struggles and challenges around technology and healthcare based on COVID the last 6 months. In addition, I think the eHealth Commission at the state has had different work groups on telehealth and other types of things like care coordination to ensure that there is sort of coordination at a state level. And it's even when we have local pilots, they're part of sort of a broader vision around what the state technology infrastructure can support.
Okay, well, I'd like to thank our panelists today. Great work. It's really great to see what's going on here in Colorado, and I'm happy that you were able to share that with everyone today. So just a little bit more housekeeping reminder, the Flipgrids, the link is in your chat box if you'd like to go visit the student presentations and the presentations related to COVID, population mental health work. And then our afternoon sessions will start at 12:30 with a session on integrative care, as well as a session on ACEs and early prevention, followed by our latter two sessions starting at 2 o'clock. So hopefully we'll see you this afternoon. Thank you again for attending.